So welcome. My name is Dr. Arlene Cox. I'm a clinical psychologist at the Calgary Chronic Pain Centre, and it's my honor to be doing the Explaining Pain presentation for you today. And we focus our program on starting with this information because we truly believe this quote from the Explaining Pain Handbook, that understanding our pain is one of the most important things we can do in order to move towards recovery. And we do believe in the word recovery in the sense of we can help things change and move towards improved quality of life. And we also want to start with reviewing pain physiology and what we know, because literally what we know keeps changing, and we think it's essential that we all keep up to date with what our technology is teaching us. We also want to honor that those of you watching this presentation and the clients coming to our center already know a lot about pain. We by no means want to imply that we have to teach you, since we understand your search for understanding, your effort to make a difference. We want to honor that experience, and we also want to make sure that we're both on the same page of what the latest pain knowledge is teaching us and highlighting to help us and you change your pain. And partly I want to highlight what the Chronic Pain Centre does. So this is our next steps map. This map is what we would consider the forest, so the overall look of who and what we offer here at the center. So it gives a list of the variety of healthcare providers. It also highlights the different groups we have at the center, and also other programs or information available to you that might be helpful in your journey to improve your quality of life. And so today we're doing the first of the groups available at the center, the Explaining Pain presentation. And at the end of this presentation, I'll talk more about what next steps are available to you. So our focus today is on exploring what is pain, the systems involved, the overall neurophysiology, and how persistent pain changes us over time, concepts of sensitization, both central and peripheral, and also concepts of neuroplasticity. So that idea that the brain itself is literally changing moment to moment. We'll also be exploring what you can do to change that system, what we're aware of now, what tools you might need, and what are realistic expectations. And last, we'll review that next steps map and highlight what might be useful next steps for you. And this slide highlights where the majority of the information presented today comes from. We've been working on explaining pain as an actual treatment for pain for over a decade now. The original Explain Pain book came out in 2003, and the two authors, Lorimer Moseley and David Butler, have been integral to the growing understanding of pain. Lorimer Moseley is a professor, a physiotherapist who is a clinical scientist, professor of clinical neuroscience, and a chair in physiotherapy at the University of South Australia. He's been in Calgary before and will be again in 2018, and is one of the leaders in pain research and clinical use of that research. And David Butler is a physical therapist with advanced training in manipulative treatments, as well as a master's in research and a PhD in education. And together they are leading the push to have pain knowledge as part of treatment, as it helps us and literally results in less pain, less disability, and less worry about pain. And there is clear evidence that as we have greater understanding of pain and what's operating in our own bodies, that literally helps us retrain and shift the brain's focus. And a main issue for what we're highlighting today is that pain knowledge changes. As we learned that the world wasn't flat, with more information and more technology and an ability to be aware of that information, we are now shifting from an idea that pain is a sign of tissue damage or pathology, that it's simply a response to your health and it is an accurate indication of that health, that there are things called pain pathways or nerves that create that experience of pain. and looking at it from a simple medical or biological model. So this pain knowledge is outdated. It never explained the variety of our experience well. And so we're always looking for models that better explain the data or our information and experience. So currently, the model we use is the biopsychosocial model, the one that recognizes that our biology, our psychology, even the social context make a difference and impact the experience of pain. The model that understands pain as a sign of the brain's perceived need to protect the body. So it's always about protection, and it's always based on the brain's perception of that need. And last, it is meaningful. In the old use of pain, if pain seemed to go on longer than was needed because of healing, it was considered meaningless. And this is inaccurate and does not fit what we understand now about body and body tissue and brain. Pain is meaningful. However, it is not an accurate indication of the state of your health in this moment. And the more we understand that complexity, the more we can understand what meaning there is. We also understand that everything in our system is involved. Part of why it is a biopsychosocial model. It's not just about nerves or the nervous system. It's also about the respiratory system, the endocrine or hormonal system, our joints, our bones, our thoughts, our feelings, our immune system. All of it play a role in giving information to the brain, which it will use to make that decision. And the reality is, I always feel like I'm preaching to the choir, because my clients know this. They know that over time, as their pain has persisted, things have changed. They've recognized that they get sick easier, that they have more stress. When they have more stress, more anxiety, more anger, more frustration, their pain it gets higher. And vice versa, as their pain gets up, there's more stress, anxiety. That sleep is different. And even if they seem to sleep for hours and hours, they don't feel rested. That's if they're lucky enough to sleep at all. And there's a sense of fatigue. And it's not just being tired, it's a sense that almost as if gravity is greater on you, that you're moving through with greater weight or burden on your body. And over time, more things start to hurt. So doing some things that were okay before now becomes less okay. And pain starts sooner and lasts longer. And you get lots of advice to stay positive, and that positive self-talk is important, and that it's very difficult to stay positive when you see this and experience this progression. And even if you have people around you, often it's an extremely isolating experience to have pain. And when others don't understand, it can be even more isolating. And we know how complex it is. We know that those old days of using does hurt equal harm. So when I hurt, that means there's injury. Most of us have had that experience and well aware that we can have an injury and not have pain right away, of wonder where that bruise came from or why there's blood running down our arm. And I use that cute cartoon of a shark to highlight there's lots of documented evidence of people having quite horrific injuries, perhaps as a surfer in Australia with a shark bite and losing a limb, that we don't initially have pain in these circumstances, and that a stress or sympathetic response does not explain this. And then on the other side of the coin is that injury that seems so small and yet takes our attention, that paper cut, that has so much pain with it, and yet the injury is quite minor. So over and over, we have clear, consistent evidence that pain and tissue damage are poorly related. Tissue damage alone cannot explain our pain experience. And even that Slurpee cup, that idea of that freezy head we can get, when we know quite clearly the ice is in our throat, and yet the pain is in our forehead. We know that there isn't a clear connection here. And you'll see this slide over and over through the presentation, these ideas of what are our take-home points? What point do we truly want you to take with you today to understand? And that pain is a brain output always, and it's designed to protect you. It is not random, it is not malicious, it's always about protection. And also, our entire body's involved. That it's not just one area of the brain or one part of your body that plays a role in this experience for you. And it's not just about injury or damage. And having said that, we don't mean injury or damage aren't relevant or related. Absolutely they are, but they are not enough to help us understand truly what chronic pain is. So when do we have pain? And a model we can use, a metaphor we can use, is this sense of a balance, a weight of evidence of danger or messages of danger coming in versus messages of safety. So we'll have pain when there's more evidence or messages of danger than there are of safety. And it can be made that simple. And what are these messages? So if there's messages about safety, it's any message that our brain is receiving that helps us feel stronger, that we are strong, that we're feeling better, we're feeling healthy, we're feeling confident. So any message that helps us feel sure or certain of who we are, what we are, of being simply me, those are messages of safety. So when I feel right, okay, normal, then that's about feeling safe. And messages of danger are any message that we receive, that our brain or system receives, that lets us know there's danger to our body or our tissues, our life, our lifestyle, our job, our happiness, our day-to-day function. Any threat in any of that creates messages of danger that are part of this balance. And any message we receive, any message coming into our brain and system can be collapsed into one of these 7 categories. So let's think about that. So things that we hear, see, smell, taste, touch, those sensory messages coming in can be a sign that we're in a safe experience or environment or a dangerous one. There's things I do that are feeling either safe or dangerous. There's things I say. So that uh-oh is never a message of safety. There's things I think and believe about who I am, what's going on, what I can expect, what's happened in the past that are messages of safety or danger. There's places I go, places I feel safer literally, and places I feel more danger or threat. There's people in my life that represent safety or danger. And then I also recognize that there are people that at times vary. So sometimes they are more likely to be a dim or a sim. And last and not least, things happening in my body, sensations or experience, things I know going on that I may not even feel, but I know are happening, that can help me feel safer or in danger. And another way of thinking about it is if this is a measure of a protectometer. So like a thermometer, where the mercury rises as the temperature increases, this protectometer, the measure or the indicator rises as danger increases. So as there's more danger messages coming into the system, that indicator will rise and rise until we're in the danger zone, which is more of the pain zone. And if I have more messages of safety, the system feels calmer, quieter, and more in that safe zone. Then we're going to have less of that protection needed. And as indicating, this is a sliding scale. And what we mean by that is our experience is changing all the time, as the brain is constantly being updated and aware of those messages, that balance of danger and safety, that indicator can slide. And it's based on the messages received and what we're paying attention to. And we start to learn that the literal act of paying attention plays an important role of what the brain attends to. And there are a number of choices for protection. So our brain can choose to stimulate a variety of systems to let us know that a need to protect us is increasing. And we might notice something in our sleep pattern to start. And maybe it's more difficult to fall asleep, or we wake more easily, we don't feel rested. And we might notice changes in sweating or heat of our body. We might notice muscle spasms increasing. We might notice that it's difficult to think straight, or we might have odd feelings in our body. And that indicator gets a little higher. The brain's producing a little more systems for protection. And then we might notice we're having a short fuse. We're more impatient. We worry more. It's harder to focus. Our job feels less satisfying. Life may be less satisfying. And we notice an impact on our relationships, and maybe an increasing feeling of fatigue all the time. So now that indicator is in a place where we're more in that kind of alert zone, where we're almost primed to move into that pain zone. And then if those protective systems are turned on and switched on all the time, then it becomes inevitable that the pain system starts to get produced. That pain is the most powerful behavior-changing system we have, and we're more likely to move into that system. So take-home points continue with the brain is always focused on protection. That pain is one of a variety of protection systems it has, and that whatever is going on in our life in that moment influences our pain. And it's a balance between messages of safety and messages of danger. So how does it work literally? Well, we have a variety of nerve cells in our body, and they provide information. The peripheral nerve cells provide information to the spinal cord, which sends information to the brain. And if I was doing this presentation a year ago, I'd tell you about mechanical receptors and temperature receptors and chemical receptors. So there's nerve cells that really only pay attention to mechanical change in our body. As we move our joints, our tissues, they're aware of those changes. And we have nerve cells that pay attention to temperature change in our body, caring about internal temperature change, external, and respond when that changes to that. And then we have chemical nerve cells that particularly pay attention to chemical change, perhaps on our skin, but most within our system, between the cells, around the cells, and that these cells, a chemical cell really isn't interested in mechanical change, etc. However, we're now learning, and again, as our technology improves, we'll learn more, that with practice, over time, mechanical cells can learn to pay attention to chemical change, and chemical cells can learn to pay attention to mechanical change. So there's even more complexity than we realized. And then there's a fourth kind of cell, a nociceptor, a danger cell. So a cell responds to danger. So if any of these cells, if there's enough change in what they're paying attention to, what they care about, then they'll fire. We often call it firing because within a cell it's an electrical response. And enough change happens, then that cell reaches its threshold or tipping point. And what's even more interesting is that threshold changes. It's not set in stone. Each cell can become either more reactive or less reactive. And that can happen with practice, with training, and our attention. And each cell communicates with other cells through chemistry. So, unlike the wiring in a house, these cells do not connect at junction boxes. They connect by sending chemistry or chemicals across a tiny gap between them. And although this slide you're looking at is two-dimensional, you can imagine three-dimensional. So there's cells surrounding each cell, so each cell can connect and interact with and send chemicals to impact hundreds of cells around them. And as they share that chemistry, they can impact the cells to either fire more often or less often around them. So the cell message, the chemical message, can vary depending on which chemical is released. And again, if I had been doing this presentation a couple of years ago, we'd have stopped there. Already there's a complexity in the variety or kind of chemical. There's a complexity in what that chemical does to different cells. There's a complexity and how practice impacts that. But we're also now aware that there are other cells around nerve cells called glial cells. And there are millions of these cells in our body, and they play a role in that pattern of reaction as well. And that some of these glial cells have an inflammatory or excitatory role, and some of them have an anti-inflammatory or calming role. And again, with practice and attention, they can increase their firing or impact. So they play a role in whether a pathway gets more inflamed, more excited, or less so over time. And then all of these messages constantly feeding information to our brain. And this picture from the Explained Pain Handbook shows the variety of areas that are paying attention, the combination they make, and again, the complexity. This brain is not a warehouse that stores information. It's actively working with, weighing the need to pay attention to different information coming in. And always, it's how is most useful to us. And that's an unusual word to likely hear when we're talking about pain. How is pain useful? How is it useful for our brains to be responding in this way? And it's taken me about 20 minutes usually to get to this place where we talk about how the brain has created that experience of pain. And yet your experience is instant. It happens immediately. We don't have to do this working through. It's not as if we're making this decision to have pain consciously. This decision is based on the brain's perception of the need to protect you. And we need to make sure that we don't confuse the word perception with the word belief. They're very different. So let's consider an example of what a useful perception might be. So this is a relatively famous optical illusion. What we're looking at is a checkerboard. And as you see, there's a square labeled A, second from the left at the top. And that square labeled A has a certain color that we perceive. And then you see there's a second square labeled B, which is third from the left in the center. And the question is the square A the same color as the square B? And as we look at this now, we can see that they're not the same color. That A is quite clearly a dark gray square, and B is quite clearly a lighter gray square. We can see that we're looking at a common, usual checkerboard, which we know has alternating light and dark squares. We can also see there's a green cylinder on this checkerboard, and there seems to be a light source, as there's a shadow across the board created by that cylinder. And putting all these things together, this is a useful way to see this two-dimensional picture. We see a sense of depth, we see a sense of light source, and this is how we've learned to interact with our world, and that is a very useful way to do it. However, if we add more information, we now see that the square A and the square B are exactly the same color. So this is as it is. And yet we did not perceive this until we added more or new information. And now we see it quite clearly. However, if I go back and take away that information, we again see and perceive this as two very different colored squares. And think of that example. As I give you more information, I perceive it as two squares of the same color. As I take away that extra information, I'm now back to seeing it as two different squares. Yet the information hitting the retina of my eye is exactly the same. My eye sees it as it is. However, that information is sent to the brain, the occipital area of the brain, which is more our visual cortex, and it's put together, and it's not seen as a useful way until I add more information. So just like being reassured verbally that, hey, I now know these are the same color, and I could talk to myself about it and encourage myself to perceive it differently. But until I give my brain literally more information, that's not enough to change the perception. So telling yourself you're safe, that your injury's healed, that you don't need to feel pain, isn't going to work. It never has, and it never will. We need to give the brain new information so it can literally change your perception in order to change pain. And when we talk about the brain choice, we want to highlight this is not conscious. The mechanisms, the information going on, the majority aren't even in our awareness. I am certainly not aware of the hue and density of color hitting my retina. I'm only aware of what I perceive. I'm not aware of the variety of systems. I'm not aware of endocrine levels or immune levels or tissues in my body in particular detail. So I know my brain puts all this information together, and it does it in a way that helps me respond to my world in the most useful, the most familiar, and the way that feels safe. Always as is useful. Another example is this presentation, this picture, that some people see as an older woman, and some people see as a young woman. And as we look at that picture and start to trace, perhaps if we look at that as a nose, so rather than the jawline of a young woman, it can be the nose of an older woman. And rather than a necklace, it's her mouth. We can start to see both pictures. And we're actually training our brain to see both pictures as we practice, changing it. Or we might look at this cube. So sometimes the face can vary with what we pay attention to. So we can change our experience based on what we perceive and what we notice. And this also leads us to recognize how important context is. Because perception is greatly based on context. And in one particular research that Lorimer Moseley did, and you can see the YouTube connect to that if you'd like to watch him describe it, his subjects volunteered to have a pain experience. And so a minus 20 degrees Celsius bar was placed on their hand. And this is painfully cold. And the only difference between the two groups was the color of the light that was shone at the same time. So both groups had a minus 20 degrees Celsius bar placed on their hand. Both rated the pain levels they felt. One group had a blue light, and one group had a red light shining at the same time. And the group that had the blue light shining had significantly less pain on a 0 to 10 scale, 5 points less on average. And the bar felt cold. Those with the red light felt much more pain, and the rod felt hot. And the only difference was the context that the light gave it. So this is a powerful example of what context can do to our experience. What other information, when you think of those 7 categories of message, the sensory experience, the place, what you're thinking, your history with that experience. So red lights have always meant danger for us. They're always a warning. Often red also means heat. So we can understand why that experience was different. It makes sense. It was more useful for us to perceive this in general. So all of these messages matter. They all play a significant role to create that sense, that experience of context, and whether or not our brain will decide that pain is the right experience to have to protect you. And it's not linear. It's not like one builds on the other. It's emergent, which means they all connect in the same moment. They all have a role to play. And it also means, like those old-fashioned lights we used to have on the Christmas tree, where if I took one of those bulbs out and added a flasher bulb, then they would all flash. Now, if I change one of these messages, it has an influence on the weighting of all of them. Building our take-home points, pain is dependent on context, on that balance of danger and safety, and context plays a significant role in that. So when do we not have pain? When does the brain not perceive a need to protect us with pain? And it does not mean that those nociceptors or danger cells aren't firing. They could be. But the weighing of DIMS and SIMS, there's more SIMS than DIMS, so pain is not produced. And our brain has a number of options in what to do to decrease that pain experience. The majority of them are through chemistry, through those neurochemicals. Some of them are probably familiar to you. You've likely heard of endorphins, those naturally occurring painkillers. And that's a larger name for them. There are specific ones that work on buprenorphine receptors and kynorphine receptors, dynorphin receptors, different places, different roles in our body. Dopamine and serotonin are neurotransmitters we produce. Again, you may have heard of the term or word serotonin. Antidepressants often focus on increasing the serotonin available to us. We know that higher levels of serotonin in our brain help us feel more positive, help us have less experience of pain. However, we also know that higher levels of serotonin in our knee joint is an inflammatory chemical that increases the likelihood of pain. So part of why we struggle with medications that we take when we try and influence these naturally occurring chemicals or receptor sites artificially is we do not yet have the technology or understanding of how to target medications well. Whereas our own naturally produced chemicals, no side effects, beautifully targeted. So majority of effective pain treatment is often focused on improving the production of this internal chemistry. We also found that there seemed to be three themes for when pain is not useful, not the most useful thing in this moment. And sometimes it's about immediate threat. So we don't feel pain because it would distract us from the more immediate task of surviving. So we've been in a car accident and the car is burning and we know we need to get out, or we need to get ourselves and our children out, and we do that. And we tolerate quite significant injuries, perhaps noticing after the fact that our leg is broken, for example. And there are numbers of stories of people returning to burning buildings, not aware of the damage they themselves are receiving until afterwards, because they're so focused on saving family or important items. And we also have the military example. Over and over there's examples of the military soldiers not feeling the same pain levels in those environments. They need to survive first. And it was in the 60s, when more of this information was coming about, that we started to explore how could a model of pain better explain this varying experience. So although there is injury, there are nociceptors firing, there's all kinds of nerve activity. The brain is choosing not to experience pain in that moment because it is not useful and will not help us survive. Or there's the example of context, that in the past, the context has been safe. So that safe context and expectation is what rules the brain. And Lorimer Moseley himself is an excellent example of this. And we like to use this one in particular, not just because you can YouTube it and get the story from his own mouth over and over, but also because he knows the physiology, he knows what's happening, and yet, regardless of that, his brain still responds like our brains do. That context is huge. So he was walking in the bush, and Lorimer is Australian, and the bush in Australia has many small thorny bushes. So having scratches on your leg is highly common. He states he may, as a youngster, have been called scratchy. So he's camping with friends. It's early in the morning. He chooses to walk to the river alone to swim, and will describe feeling a tug on his left calf. Ignoring this, thinking it's yet another scratch, moving towards the river and swimming, and then waking up in a hospital, and not really recalling anything else. So what was the as it is? What was the truth of what was happening in his tissues, the nerves themselves? The fact was he was bitten by a brown snake. So that tug on his calf wasn't a scratch, it was a snake bite. And those snake fangs would have punctured his skin and injected a venom. And there were all kinds of changes. There were mechanical changes, and there was lots of chemical changes. Messages of danger from the tissues to the spine to the brain. And yet his brain, because it wasn't useful, it wasn't common or expected, ignored those messages, did not produce pain. And really, Lorimer should not have survived. This is quite a deadly snake bite. However, they expect that he likely did because he was in the cool rivers. There was less movement. And he was found and taken to the hospital. He wakes up and he notes that he had ongoing groin pain because of the changes through his blood vessel in his leg for a week or so after. Sometimes we don't have pain because of immediate threat, and sometimes we don't have pain because of context. And last, sometimes we don't have pain because that change is slow. It's a gradual change in our bodies. And our bodies are weird and wonderful things with all kinds of knobs and bumps. And one human doesn't look the same as the next, and one side of our bodies doesn't look the same as the other. So if change is slow, then pain may not be useful. And we're learning more and more that when we look at MRI findings of osteoarthritis, there are people that have literally in their knees what looks like bone on bone, and yet they don't have pain. And there's other people that have a beautiful shape to their knee joint, and they have quite vicious levels of pain. So you'll notice that thumb flipping a coin, because I don't know from their MRI findings if they have pain unless I ask. And then think of low back changes, disc changes in our back. We hear over and over the term degenerative disc disease. Over time, our discs degenerate, they change. I can't think of anything safe about the term degenerate, progress, disease. And the picture you see on the slide is highlighting a disc bulge at L5-S1. And we can see that bulge looks like it's impacting the spinal cord. Yet this picture was chosen for the very fact that the person this was taken a picture of doesn't have back pain. They don't have back pain or radiating leg pain. They have no pain at all. And yet their picture is pretty scary. So again, we know over and over that simply what the image tells us does not tell us about pain at all. And if we know that, then perhaps we can react differently to these images. And it's also part of why there's a shifting focus on why would I take an image. If the image doesn't help me understand your pain, then perhaps it's not a useful thing, because I'm probably going to find something. I'm going to find something on most people's images, because we're all growing and changing over time. We're now learning more about meniscus tears, and again, not terribly meaningful for pain. We're learning lots about rotator cuff tears, and again, I can find tears and partial tears in most people out there, and it does not mean they'll have pain or even changes to function. So the kind of reasons nowadays that we order MRIs are about function. I can't lift my foot. I have bladder and bowel problems. Then we'll start looking at getting an MRI, because the response to surgery is actually quite positive if I have those mechanical changes. We have more and more evidence that doing surgeries for sensory changes like pain or numbness are ineffective and often harmful. They change things in the wrong way. So overall, our brain will not produce pain, or it will produce less pain when it's not useful. And it cannot be useful because we need to survive and do something different, or it's not useful because of context or slow change. So when is it useful? And again, isn't that an interesting way to think about it now? That pain itself is protection and usefulness. And if we have more evidence of danger, more of those DIMS messages, danger messages, then we're likely to feel pain. So going back to Lorman, again, part of the reason we use his example is it's such a lovely representation of this shift, of all the variety of biopsychosocial messages that create this experience. So 9 months later, he's walking in the bush again, he's talking to someone, he's somewhat distracted, and he describes a, quote, white-hot poker pain in his left leg. He agrees he may have made a fair bit of fuss, he might have made some noise. His friends around him are shocked, they're surprised, they're wondering if has he again been bitten by a snake. And this time it's a different story, because as it is a tiny scratch, like it was so many times before. His experience, what the brain saw as useful, was agony, because we learn fast what can kill us. And his brain would have been saying, hey, last time we ignored this, buddy, you almost died. We were paying attention. So no longer was the context of safety, right? The context was of danger. And again, I've highlighted a YouTube you could go to if you want to hear Lorimer tell his story himself. And what's happening with this? This was one-time dramatic learning. And the reality is, pain is one of a variety of experiences. And all of our experiences have some representation, some brain pattern. Our memories, our experiences, our skills are all patterns of activity in our brain. And I can imagine there's a pattern of activity in my brain for chocolate, and it might look like this. We have patterns of activity for everything: our phone number, the smell, the experience of a rose, playing hockey, whether we're good at it or bad at it. I imagine that maybe the representation of French fries from my brain might have this kind of pattern. And our brain patterns are constantly changing and updating. And it's about what's happening together in time, what's connected for us. And nerves that fire together wire together. And again, it's not like the wiring in a house where they're literally connected. But if we think about the way those cells connect, if they fire together, the chemistry, they're more likely to have branches reaching out to each other. They'll respond faster to the chemicals. It'll take less of the chemical to create a firing pattern in the next. With practice, with attention, with training, these patterns become stronger, more likely to fire deeper. And we used to think that patterns, once laid down as an adult, were done. And we now know that's not true at all. That they change minute to minute, day to day. And as our technology improves, we're able to see these, literally see these brain changes from week to week. And neuroplasticity is that term for brain changes. How plastic our brain is, how moldable. Although it's difficult to draw that in a diagram, there's over 500 areas of our brain that are busy when we're experiencing pain. So it's not a simple pattern at all. And over time, with practice, more and more connections are made, new areas are linked in, more connections with motor, sensory, mood, all play a role with pain. And literally our brain changes, the density of the tissue changes, the response and connections. And this slide here is showing the motor cortex of the brain. So it's showing you a slice of that cortex that's involved in our body and moving our body. And we've taken that slice and shown you the cross-section. What we're highlighting here is that the map of your body on your brain, it varies depending on what part and how much we're able to move it and how important it is, again, to our survival. We evolved effectively because of those hands of ours, of those opposable thumbs, of that ability. We have a great variety of fine motor movements available to us with our hands. So a large part of our brain is literally around moving that hand. Next to the motor cortex is the sensory cortex. It has a very similar map with a large part of the sensory experience of our brain to our hand. And again, a large part goes to our face, the ability to move and create expressions, to move our mouths, our tongues, to communicate, to eat. And again, we evolved as social animals. So it's important for us to be able to perceive and understand those facial communication, to communicate through sound. So we're highlighting again that a large part of our brain is connected to these parts. And that's how it generally is useful. With practice, with training, with attention, those parts change in how much are assigned. So a violinist, the hand representation for a violinist, a guitar player, a piano player, is greater than it is for the average person. And the foot representation increases for a soccer player than it does a violinist. So again, with practice and training, more of the brain is used for what's useful, for what's important to us. And then it turns out it's not just about use. We've learned from the phantom limb research, from those people who've had body parts amputated, that the brain map, if I lose my right hand, the brain map for my right hand starts to change. The borders between my hand and my fingers starts to actually blur or smudge. And we start to see that that has a very negative impact on our experience. And with those experiences with the phantom limb folk, we learn to look, are those same changes happening with folks with persistent or chronic pain? And they do. So someone who has a painful right hand also has that blurring or smudging. Now, I don't have any personal experience of that kind of change at my brain level. What I experience is my body differently. And what we see are changes in how people are able to move in space. Their coordination changes. They're more clumsy. They start to feel their pain spreading. They start to feel new sensation. So they might have newer burning pain or shooting pain that they didn't have before. And we hear quotes like, "It doesn't feel like my arm anymore. It's not a part of me," or "I don't like it. I hate it almost. It feels wrong or different." And we know that part of that experience is based on those cortical level changes. So what we're seeing is it's a whole system change, a whole system wind up over time as pain persists. And literally there's changes in how we perceive our body. So when we take digital pictures of someone's painful right arm, and then we digitally change those pictures so we can make the arm a little smaller, and then a little smaller, then a little smaller, and then we can also make the arm look a little bigger and a little bigger. And then we show them those range of pictures. People always pick the bigger arm because that painful arm feels bigger or swollen or stiff. And we're starting to see that a lot of that extra swelling or stiffness feel is a centrally driven brain down perception that actually isn't in the tissues themselves. And we see that and hear that people start to hate, disconnect from, feel apart from that body part. And we also know that that experience changes the blood flow to that area. So if I'm rejecting and hating and feeling apart from a body part, there's less blood flow. There's often a literal coolness to the tissues. And we also see changes to the immune system. And we'll feel more aches and pains. We'll feel more fatigue, and it's a different depth or level to that fatigue. And we're less able to respond to illnesses or sicknesses. We see changes in the respiration system. The breathing changes. It's more in that high, short, shallow breath, often leading us to feel more lightheaded, to have less availability or shortness of breath, to feel restricted in how we breathe. And it's a constant message. It's a circular message, right? So if we have this more stressed, fearful, under threat breathing going on, it's a feedback into the system that we aren't safe, that we aren't in the right place or balanced. The motor system changes. Muscles become more and more tight, protected, guarded. And again, this is not specifically under our conscious control. We may increase that tightness, but there's habits become of bracing and guarding. The movements themselves are no longer fluid. They're more jerky or rigid. It's difficult to move things easily or smoothly, which again provides feedback that things aren't right. There's responses, there's a stiffness. We feel and tense up, grimace, groan, again contributing to that message that things aren't okay. The sympathetic nervous system changes, fired up more. So of that autonomic system that's balancing how we digest, what's supposed to be our repair, our digest system, the sympathetic system, the stress system, is more in operation. We're under threat. We're ready and prepared. It impacts our ability to sleep and the impact we get from sleep. Changes in sweating, restless, agitated, changes to our hormone system, which impacts tissue healing. And an interesting study, a simple study on dental students who volunteered to have a 1 centimeter cut on the roof of their mouth, and the dramatic difference in healing: 7 days of healing during vacation, 10 days of healing during exams. And in a simple, relatively expected, short-lived experience, and the dramatic difference in tissue healing, you can imagine what persistent pain does over time to our ability to bounce back, to recover. Changes in our language, and again, the message and feedback that gives us. Changes in our thoughts, more focus on worry, more negative. As we feel things progress and wind up, feeling less powerful, more hopeless that we can change this. Less confidence, more likely to avoid people and activity, more likely to do less and less. The brain focused on this more and more, and an overall overwhelming experience. So again, a full system wind up. And if you don't have all of the things on this very scary slide, by no means am I saying you'll get there. But if we continue to respond to pain as a simple medical or biological way, these consequences are more likely to happen. We need to have a full system response to change this. The kinds of diagnoses we see and hear here at the center really represent that great range of impact. Even the headache diagnoses we see in our headache program, migraine, not a simple experience, having full body connections to medication overuse headache, which even is a dim when you hear it, because there's almost a perception of blame in that what I was using to help me cope is now actually contributing. And it's the same with the opioid crisis that we're in right now. Opioids, medications we gave people to help or cope, are now having very negative consequences and clear signs they can literally ramp up the pain system rather than calm it down. And sometimes even a phrase like tension type headache, it just doesn't seem like a powerful enough diagnosis to really help explain the vicious pain that this can cause. And yet that is part of the mix. We'll see combinations of these. Many of our clients have a variety of these diagnoses. And what we're hoping is over time, having a diagnosis of this becomes more of a safety message, because it doesn't mean something dangerous or malignant like cancer is going on. And there are things that can be done to help you shift your experience over time. So why does it last? Why does pain last? Why does this system learn like this and connect like this? So there are some things that we know. We literally know for all of the clients coming to our chronic pain center, if you have persistent or chronic pain, the longer your nervous system has this experience, the more it adapts. We are designed to adapt and learn. And sometimes that works against us. We are designed to create skills to sensitize, and we're designed to have that peripheral system and that central system sensitize. But what that means for you is that our danger cells can fire more easily. What used to be a range of movement that was in the safe zone becomes smaller and smaller. And when those danger cells fire, that act of firing, that electrical pulse, the release of the chemical lasts longer. So more chemical is being spread. And the next cells, the danger cells in line, become more sensitive to a wider range of neurotransmitters. So more of the chemistry is released. I need less of it to fire. I respond to a greater variety. So if I release adrenaline, cells that weren't that interested in responding to adrenaline learn to respond to adrenaline. If I release cortisol, they learn because I'm bathing them in it. So over time, what I'm constantly sending out, they start to react to. And last but not least, we know brain patterns change. There have been cortical changes for every one of our clients because that is part of persistent pain. So over time, that protection system ramps up and is in that pain zone more and more. We also know that things happening at the same time can help create that persistent pain experience. Because I've had pain before. Why this time did it not stop? It stopped before, why not this time? And we can't answer that question for you. We do not yet know all of the things that play a role in this. Until we can literally predict who will have chronic pain after an injury, we clearly don't know enough. Just like the weatherman can't predict absolutely, then we're not paying enough attention, or we don't know all of the factors playing a role in whether it's the same with pain. We know some. We also know combinations have more impact. So if you have an injury, then you're more likely you're at risk for chronic pain afterwards. Yet you can have many injuries and have no chronic pain after it all. If you have an injury and you were ill at the time, or that injury gets infected, it increases your risk of chronic pain. However, you can have an infection or an illness and no injury, and that can lead to chronic pain. There have been people who have had the Norwalk virus that has led to chronic pain problems. If you have negative mood, depression, anxiety, stress, if you have a chronic state of anger, that can lead to chronic pain over time. If you were injured and were in a negative mood state at the time, that can increase. If you have post-traumatic stress symptoms, and I don't mean post-traumatic stress disorder alone, any range of symptoms can help increase our risk of chronic pain. And I also do not mean having trauma in our history. Having a traumatic experience in our history does not increase your risk of pain unless you continue to have symptoms because of it. So someone who had a traumatic time in the past, who has done excellent resolution work, who is not dealing with symptoms now, is no more at risk than someone who hasn't. However, often there's repeated traumas, or there's significant traumas, and there are ongoing symptoms that do play a role. We also have evidence that if someone is dissatisfied with their job, and if they're hurt at work, they're more likely to have persistent pain afterwards. We know that if people are injured in a motor vehicle accident and the other person does not accept responsibility, they're more likely to have chronic pain. So there are a variety of circumstances where we can wind up and almost prime us and make it more likely that persistent pain will happen. And we do a relatively good job of looking back, of having hindsight. So we see someone with chronic pain, we see that combination of events that likely led to that tipping point and kept it going over time. But what does this mean for you? What do you notice? Over and over, as we understand the complexity of pain, what we really want to highlight, what's the impact for you? Pain that occurs every day, that doesn't end, has an impact on how we feel, our strength, has an impact on our muscles, how often tight they are, how more difficult it is to move, how much more effort it is to move. We also notice that we might have a habit of overdoing and underdoing. We might push through when it's important, but then we pay later. We get frustrated with all the days it's tough to do things. So then when we do have a slightly better day, we take such great advantage of it that we set ourselves up. We set ourselves up for those down days. And then it starts to feel like a vicious cycle. We also note that it's more and more difficult to do the things that we value. And all the positive things that come from doing those valued activities, perhaps it's feeling productive, perhaps it's feeling connected, perhaps it's as simple as earning money and being able to buy the things that we want. So we're less connected to the activities, which often leads to less connected to relationships, We often notice now, perhaps we didn't before, but now it's so evident that many of our relationships are based on shared activities or ability to interact. And we're less and less able to commit because we can't predict. We don't know what it's going to be like on Friday or Monday or next week. So we might leave it to the last minute to decide if we can make it or go. And then people stop asking us because we don't commit. Or we cancel and feel bad and guilty about it. So we start to become more and more isolated. And even if when we're with people, we feel isolated because their experience is so different than ours now. And we can start to feel more and more useless, less connected, unsure of who we are, what we value, what we want. More and more likely to say things to ourselves that are discouraging. More and more critical often of ourselves. And other things we notice. The impact on our sleep. That sense of fatigue that we can never get rid of, that circular sense of I'd like to feel more motivated, I'd like to do more, I have no energy, it's even difficult to make a decision. And then we start to add medications for you, which often have side effects, which often increase that feeling of fatigue, can increase that sense of being out of it, struggling to remember, organize our thoughts. And then it's a struggle to eat. We don't feel hungry. We keep getting told that breakfast is the most important meal of the day, and yet we couldn't imagine eating. When we do eat, we don't feel good. We don't have much energy to eat. We know we're supposed to eat well. We know we're supposed to have lots of fruits and vegetables. Sometimes we can't afford them. Sometimes it's just easier to open a can of soup. It's just easy to eat some crackers. And it feels like people just don't get how hard that can be. And that isolation, that withdrawal, we feel more sad or frustrated or worried. Perhaps we're even grieving. We're more aware of our loss. And they're not even losses we can so easily highlight or recognize. The loss of waking up without hurting. The loss of sleeping easily. The loss of just deciding to do something without having to plan it over and over. The loss of just asking and getting that response that you want. Now it's hard to ask because you ask a lot. Or maybe there's no one around. And we can't concentrate and we can't decide. And now we're starting to wonder if this lousy memory is not just pain or medications, or maybe something even more scary is happening. Because it just doesn't seem to work like it did. There's such a variety of impact for people. And it has such great distress. I really want to recognize and I really want to honor that this stage of our presentation, it can feel quite overwhelming, and so we want the good news message of, can you change this? And the answer is absolutely yes. If this system is biopsychosocial, and it is, then clearly if nerves that wire together works one way, it can work the other way. If things can ramp up over time, they can wind down over time. We have to figure out what it is we need to do. What new information do we need to provide so the brain can perceive the experience differently, create your experience differently? So that question at the top, is this dangerous really? It's a curious question. That's what we want to be, curious scientists. Is this dangerous really? Is this pain telling me I need to stop, to freak out, to worry? Or is it telling me that there's a habit in the system, there's a pattern in the system, and I want to explore what one small different thing can I do right now to shift that balance? When I think of the weight of DIMS, danger messages, and SIMs, can I shift that balance in one small way over time? Because it is absolutely based on what is happening now. So if I want to change that brain, then I need to change it. And it's a skill. This learning to be less protective is a skill that we can learn. And we literally need to do things differently. We need to move our bodies differently. We need to breathe differently, speak differently, think and act differently, and be aware and mindful of what we're doing, of whether what we're doing, breathing, speaking, thinking, focusing on is more likely to build safety messages than danger. And how do we be curious? How do we literally play with that? So we want to change that protectometer over time. We want to start to look at, what are my danger messages? What are my safety messages? Is there a way for me to modify them or remove them if they're DIMS? And if not, is there a way to strengthen or add safety messages to my life? The fact is, your pain is real. This is a real neurophysiological, a real biopsychosocial experience. And if it's chronic, persistent pain, it also means that you are safe, that we need the brain to feel and perceive itself as more safe than it does right now. So, of those take-home points, again, pain is about brain output designed to protect you. It's always a brain output. All of our bodies are involved. Injury and damage may be part of the mix, but may not. And that what's going on in my life right now, in this moment, is going to influence my pain experience. And it's about the balance of safety messages and danger messages. The context of my experience will dictate whether I feel pain. Last but not least, what you practice matters. How often what you practice will play a significant role in what change you can expect. And change is realistic. Having less pain is realistic. The kinds of pain patterns we see before people come to our center are more unlike on the left, those chaotic peaks and valleys. So many times of higher pain, intense pain flare-ups, and a high baseline of pain every day. It's realistic to expect over time, making changes, adding up over time, to have fewer high pain days, to have a lower baseline, and to, when those flare-ups to happen, to be able to change them more quickly. Sadly, I'm not going to say nothing. I'm not going to say you're going to go to a place where you have no pain every day, all day. Having moments of no pain is realistic over time. It's a lot like a dimmer switch. We can dim down into that lower pain level. And the reality is less dims are going to let us get there. More sims are going to let us get there. But we're going to move in and out. We're going to keep having this flexible, plastic changes to our brain, to our systems, to our bodies over time to kind of keep moving into that zone, to teach ourselves to be there more often, to pay attention to what helps us be in that better place more often over time. And there are many tools that you can use to shift your experience, to change your brain and body. And you see the variety of tools described on this slide, from relaxation techniques to help address muscle tightness, sympathetic nervous system arousal. Relaxation impacts immune, hormone response, impacts mood, focus, attention. Sleep strategies. Just because I have pain doesn't mean I can't improve my sleep. People with pain can sleep well. Often it's learning that I have to use these strategies consistently, and I have to use a lot of them in order to shift the wind up of the pain over time. Nutrition. We're learning more and more that what we eat, when we eat it, matters and plays a role in our pain experience. The medications we use. Unfortunately, what we're learning more about with medications in pain is less can be better. But we also don't want the message that they don't have a role. Often they do. And often they can be surprising. So it may be more about an antidepressant or an anti-inflammatory or a supplement that plays a role than it is a heavy-hitting painkiller. It's finding the right kind of activity at the right level and recognizing that the place you start is unlikely to be satisfying, and yet you need to start there in order to get to where you want. Self-care. Highlighting that the self-care is an important thing that we do over time, adding up. That it needs to have a priority for us. It can't take the back seat. It can't be the last thing you think about. It needs to be part of a habit itself. Meditation, and we're learning more about mindfulness and meditation and its role for us, and exploring how that can fit for a variety of people. That it doesn't mean a 45-minute practice every night, but it could. It's something different for a variety of folk, and exploring how that can shift our system. It may be about re-examining relationships, reconnecting and renewing those, finding a way to connect with who you are now versus who you used to be. And not waiting to become that old person. It's not possible to go back in time. We have to move forward. And it might be about focusing on an energy and highlighting I need to give energy to self-care, which then is giving feedback and circular in a positive way, which helps me then have energy for relationships. It's about looking at exercise and unpacking how exercise can help. Because too often exercise is a stick people are beaten with. You must exercise. You must be more active. That's the way to shift it. And yet your experience is the more you do, the more you hurt. So we need to look at this with curious eyes. And maybe it's not about exercise. Maybe it's about moving. And moving in a different way. And getting more out of the things that you have to do in a day anyway. So you get more bang for your buck. And maybe it's about building coping skills. And really, I'm listing a variety of coping skills in general. Maybe it's about having strategies that help me redirect, to distract, to reframe. And maybe it's about creating goals that help us feel passionate again, connected, inspire us, and having them be realistic. Having a sense that there are goals I can set that I can achieve. And sometimes it's the scope of the goal that needs to change. And last but not least, it's about understanding pain. And we did that today. We talked about how pain is a biopsychosocial experience, that it's a full body brain experience, that all messages matter, and that it is something we can change over time. And if there's one phrase we want to challenge, it's the no pain, no gain phrase. This is the phrase we're comfortable with. No pain, no gain. The more we know about the systems involved and what's involved, the more sense we can have of what's happening within us, and that we can feel safer with it. These pictures you see on this slide, the top right is a functional MRI of a brain, and what you see in red is the areas that are most active. So a functional MRI shows us active areas of the brain. This is the picture of a brain of a woman in an MRI machine being asked to recruit her trans abdominis muscles, the stabilizer muscles that help with her back. She has low back pain. She's been asked to recruit her TA muscles. And she's scared. She's worried about what that's going to do and how much pain she might have from it. This picture that you're seeing is a classic scared brain activity pattern. Lots of things are ramping up right now. And it's not just the act of recruiting those muscles. The bottom right picture, this is a picture of a woman, the same woman, 2 hours later, after going through the Explain Pain Handbook with the researcher. She now has a greater understanding of chronic pain and of how recruiting these muscles can help her. Far less activity in these scared areas. What we're seeing there is the motor cortex firing away as it would like. So way more DIMS up top, way more SIMS in the bottom. Literally brain changes with understanding, with learning. Imagine how she's going to, more likely she is to be active. Imagine how she's going to set goals now. And this is hard work. This takes persistence. It takes patience. And oh my goodness, does it take courage. Because we literally are asking you to risk trying again. So many of our clients have tried so many different treatments, surgeries, injections, exercises, programs. And maybe you're here because you've had some benefit and you want to build on that. But maybe you're also here because it hasn't worked. And we're asking you to risk trying again, and that takes courage. It takes courage to try it day after day, week after week. And we are wanting to help you find that fine line between doing enough to help your system adapt and change gradually over time, but not doing too much so we flare it up and the protective systems get fired up. So we have to keep having our brains kind of ask that question, is this dangerous really? Could I do it a little bit? Could I do it a little different? Could I do it in a context, in a place, in a way where I feel a little bit safer? So I'm going to grow real slow. I'm going to start low. It's not where I'll end up. And I'm going to keep going. And this last line, it highlights there, why is there a bike? Why is there a bike? What do you need to practice about bike? It's a lovely example of what we mean. How you need to practice a lot. So this is a connection to a blog called Smarter Every Day. And it's an engineer, and this particular blog is on neuroplasticity and what he learned. And a friend built him a bike where if he turned the handlebar to the right, the front wheel went to the left, the exact opposite of what you'd expect. And you can't ride this bike if you've learned to ride a normal bike. And he was quite frustrated to see that. And you see quite a fun series of scenes where he's showing this bike to other folk and they're trying to ride it, and it seems like you could figure it out, and you can't. You literally can't. If your brain's learned one way, it can't learn quickly how to ride this bike. And he's a persistent guy, and he decided he'd practice for 5 minutes every day until he could learn how to ride it. And every time I ask this, when I present this live, people guess a variety of dates and numbers, but they never quite get to where it is. It took him 8 months, 5 minutes, every day, 8 months. So when we say start low, go slow, keep going, we really mean it. So when someone says to me, Arlene, I've been doing that relaxation strategy you suggested for 2 weeks now, and I really don't notice a big difference, you know what I'm going to ask? I'm going to ask them to keep going. Because we know these are evidence-based treatments and they work, but they take time to shift the system. And we need to have practice. And maybe it's about 5 minutes twice a day. And would it have been 4 months? Or 5 minutes 3 times a day? Would it have been 1 month? So it does need, we know a little bit of practice frequently is what changes single nerves, series of nerves, systems of nerves. We want to get to know our DIMS and SIMS. We want to explore this. We'll often use this form with clients so they can start thinking about, as I go around my day, my life, what around is there? This is a nice thing to share with your family. What DIMS and SIMS do they have? What do they notice? Some of them are there all the time. Some of them change moment to moment. So when planning treatment, chronic pain treatment, it's about what does someone with chronic pain have to do, need to do over time to get the best health outcomes and quality of life. And with the research and our experience over the years, we now know what those evidence-based action areas are. What do you already know about them? You probably already know lots about what works and what doesn't. What changes some of your messages and helps you change some of your patterns. Physical activity matters. Finding the right way for you. Nutrition, mood, stress, fatigue, energy, medications. Paying attention to pain triggers and symptoms. Looking at patterns. Having an influence. Social support. And treatment with providers are all areas that show excellent evidence that they change our messages and change our patterns. So the next steps now, after this explaining pain presentation, you might want to explore Alberta Healthy Living programs or visit our online lectures that can give more information about these topics. And you're welcome to go to any of these lectures. And I particularly like to highlight the one on attention and memory. So often people are worried about memory, and there's excellent reasons why pain gets in the way. And it's not about hardware problems. Your brain is functioning. It's about software problems. It's focusing on a whole bunch of stuff. And it's also about available to you our Alberta Healthy Living programs, particularly one called Better Choices, Better Health, that does target chronic pain. You're welcome to use those programs and other ones they offer. They also have exercise classes. They'll no longer have a fee that can occur 2 to 3 times a week. Last 9 to 12 weeks. You're welcome to connect to them to do those. We happily support that. That's not something we can offer through us. Sometimes our clients do it while they're coming to us. Sometimes they do it instead. There's also online education through the U of C. But if you're one of our clients, if you're a chronic pain center client that's been referred by your family physician, then the next step for you now is the goals workshop with us. So what is that? It's a 2-hour discussion session. It's designed for us to explore ideas and options for you around pain treatment. We'll review neurophysiology of pain. We'll identify those action areas and explore them. We'll help you set the priorities that matter to you and understand the resources available to you at the Chronic Pain Centre. And at the end, we'll help you develop your personal self-management plan for your pain. And this is an example of that plan, again, highlighting those 8 areas, evidence-based action areas, the importance of you setting the priorities and exploring the action plans that make sense for you. This goals workshop also helps us get to know you better. It's a smaller group of clients. We'll discuss things. We get to meet you and see what strengths and skills you have. And because of that, it's a confidential experience. And so we don't allow guests or children to be part of this. And that's true for all the groups going forward. We don't allow guests because confidential information comes up. And we want to support and protect our clients. So if you're interested in booking into that goals workshop, you can call that number on the screen to register or come into the Chronic Pain Centre and register at the CPC2 reception desk. And in order for your referral to our program to continue, this is an important next step. Without completing the goals workshop, we won't be able to continue with the referral. And last but not least, we do recognize that our clients struggle at times to attend. We do have a no-show late cancellation policy, so if clients consistently no-show, it identifies for us that this may not be the right time for them to be attending our program. So we do offer the phone numbers there, one for groups, one for CPC reception, which is individual appointments, either number to call if you need to cancel. And if you're running late and you know you're just not going to make it for a group, it's probably best to call and rebook. Certainly for the goals workshop, if you're later than 15 minutes in, it's too late since it's a very action-packed workshop and it's only 2 hours for once. Last, sometimes we need to contact you because we're going to cancel. I get sick, you get sick. So please make sure we have the best phone number for you. We'd like to call you to help to schedule, to let you know, and we want to stay in contact. So please don't hesitate to make sure we have the best phone number for you. So the next few slides highlight the references we used for this presentation. Also, resources that we suggest. If you would like more information, these are some helpful YouTubes. The majority of them are about an hour, from Lorimer Mosley and David Butler, the two guys who literally wrote the book on pain. And also some other resources that we've found helpful, the Understanding Pain in 5 Minutes. If you want a significant other in your life to learn more about pain, it's often easier to get them into 5 minutes than it is an hour. And 2 books that really highlight neuroplasticity and its impact. Again, those are the resources for the Brain Bicycle, the new persistent pain site that the Lorimer Mosley and David Butler's group from the NOI group have created, encourage clients with pain to explore that. And last but not least, the Pain BC site, which has excellent resources. It has resources for both healthcare providers and folks with pain. There can be online self-management, online presentations, and it's a useful one to connect to. And they offer a monthly newsletter. So again, the last slide in the program, those take-home points again, just to highlight. And I do look forward to working with you if you do come to our center. We're excited to offer a variety of groups and individual appointments that can help you, over time, increase those safety messages, decrease the danger messages, and literally improve quality of life and decrease pain. Thank you so much for your attention today. Goodbye.